So I'd like to welcome everyone to Metro Grand Rounds today. So it gives me great pleasure to introduce Dr. Sunder Mudaliar, who's a clinical professor of medicine at UCSD in endocrinology in the Department of Medicine and a staff physician at the VA San Diego. By way of background, Dr. Mudaliar completed his medical training at Stanley College at the University of Madras, went to England, then came to America, his residency in Rochester, and then his endocrine fellowship at UCSD, where he's been for the next 30 years or so. He's been a leader in clinical diabetes research, has been the site PI for multiple landmark trials, including the Diabetes Control and Complications Trial, Diabetes Prevention Program, as well as the GRADE study. In addition to his prolific scholarly output, Dr. Mudaliar has over 250 publications. He's trained generations of fellows and medical students at UCSD and the VA. And I want to say personally, when I came to UCSD about 7 years ago as a junior faculty, Dr. Mudaliar was very generous with his time. We spent many hours in his office at the VA talking about insulin resistance and important problems in that. And I have to say, I'm still very awed by your encyclopedic knowledge today. So please.
It's spilled over to GI fellows also.
Oh.
I also.
I don't know if I will do justice to your introduction, but I did include that. I served 5 years in the Indian Army as a commissioned officer, and I've served in what's the highest hospital in the world at 14,400 feet. And just for the background.
That's on your CV.
Thank you all for attending. It's my pleasure to try and take you on a journey of diabetes treatment through the ages, from diets to insulins to incretins to Gliflozins and beyond. Those are my duality of, I get research support from the NIH. Sun Pharma is a company in India. I do occasional consulting. They're making some GLP molecules. I'll not talk about it. So these are my objectives. I will trace the evolution of diabetes therapies over the centuries, from diets to the discovery of insulin in 1923. Then I will describe the advances in diabetes medications in the post-insulin era, from the 1930s to the early 2000s. Then this is the big thing. The major paradigm shift which has occurred in diabetes treatment with the introduction of the Gliflozins, the SGLT2 inhibitors, and the GLP-1 analogs. And last, I will hazard a look into the future of diabetes medications and diabetes management strategies. Diabetes is a very ancient disease. And if you look at the literature, it says the first description of diabetes was by Areteus of Cappadocia in the 1st century of the Common Era. And he said that this doesn't work. It's likely to, he described the case probably of type 1, and he said it's a melting down of the flesh into the urine with very short survival. And the word diabetes in Greek means siphon or a tube. Water just passes through you. A fellow Greek of his, that was Galen in the 2nd century, he described it as a disease specific to the kidneys because of a weakness in the retentive factor. That's what he wrote. Probably one of the early nephrologists over there. Anyway, but if you want the real history of diabetes, you have to go back 5,000 years to the time of the pharaohs. This was a commemorative stamp issued by Egypt in 1971. And those if you really want, somebody will say there's no Egypt there. It's UAR. In 1971, there was no Egypt. It was the United Arab Republic of Egypt and Syria. It collapsed, but that's different. And then this describes the pharaoh Hesira around 3000 BC, and he was the pharaoh to he was the physician to the pharaoh Djoser in the 3rd dynasty of the Old Kingdom. So this is about 1500 years before Tutankhamun. So it's from there. And he has written down something which is called the Ebers Papyrus, and that is it. And if you want to see it today, it exists. in the University of Leipzig in Germany. And I have pictures of the original one. It's on a scroll and you can look at it. But if you will notice, this is not hieroglyphics. This is his cartouche, which is in hieroglyphics. The Egyptians wrote in 2 other languages. This is cursive hieratic. And they also wrote in Demotic after that. But what did he say over here? Ebers himself, he was a German Egyptologist and he bought it from somebody in the bazaars of Luxor in the 1800s. And this, it's fascinating. You look at the cardiovascular system, you look at the bones, you look at reproductive. This is about the urinary system. And he described something just like diabetes. And he said you can correct it in 3 ways. You can give a rectal injection of olive oil, honey, sweet pear seed salt. That must be pretty painful. Even more disgusting, you could anoint the phallus. I don't know why. But the third was by means of mixtures. And among others, that's fresh milk, beer swirl. The Egyptians were very good. And the Sumerians, they learned it from that. They brewed beer very nicely. And green dish, nobody knows what it is. He said, make it into one, strain it, combination treatment for 4 years. That's what he said over there. The sweetness of it is probably ascribed to Charaka, who in the Charaka Samhita, and he wrote in Sanskrit, probably in the 1st century AD, he was the physician in the time of Kanishka the Great. And he said, the urine is sweet, the ants come and they come for it over there. And then what happened? So they found out what it was and you saw those treatments. But how did we treat it over the centuries? It was purely empiric and mainly dietary restriction, manipulation. They added a bunch of substances, some of which might be considered drug. And it is, he said, a non-irritating diet of milk, carbohydrates, hiera, nardum, moxic, they're all herbs. And thieric actually contains viper flesh. I looked it up. Some of them are available on Amazon in case you want. I don't know. The meatus of immediate, this was a treatment in the old day. You bleed the patient out. It occurred in the 1500s. Emetics, purge the system. But don't forget the narcotics. You got to give that. And Avicenna, now we're coming to the end of the 1st millennium. The Arab physician, he said, use all these herbs, fenugreek, lupin, wormseed, and all that. So let's get into the next millennium. We're coming in the 1700s. And John Rollo was a Surgeon General in the Royal Artillery. And he talked about the meat diet. And he published it actually. And he published it in 2 cases in the Royal College of Physicians. It was a London publication. And for those that I love reading the Roman numerals, there are very few people around who can. I can tell you exactly, but it's 1798 over there. But I was very interested among the other articles, the results and trials of various acids and other substances in the treatment of Luis venerea. Those of us old enough knows Luis venerea is none other than syphilis. Well, and they use a whole bunch of substances for that. But what was the meat diet? High fat, high protein, low carb, as you might expect, and only animal products, no plants. And his typical morning meal was blood and tallow, served in the form of pudding. For lunch, there was venison or other old, rancid, fatty meats, such as pork. But guess what? It worked. And he's published it, 2 cases and much after that. We come into the 1800s and it's Apollinaire Bouchardin, and he's considered the father of diabetology. Why? Because he transformed Rollo's treatment and he said, individualize the treatment. Now we have to remember at this time, nobody knew type 1, type 2, that they didn't know. They just gave treatment. And he forbade milk because of its carbohydrate. And he said, eat as little as possible, pretty good, and masticate carefully. And he introduced intelligent use of exercise. And not the least, he said, check the urine daily to make sure that the sugar doesn't come back, because everybody's diet tends to, go degrade over a period of time. And he had to prescribe something else, soda bicarb, chalk, magnesia, citrate, tartrate, ammonium. You got the works over there. We come into the 1900s, the oat cure, Frederick Allen, and this is in the Harvard University Press. The book is still, all these books are still available, and thanks to Google, you can get the thing over there. He said, absolutely no other carbohydrate other than oats is to be given. And others, you lose everything, all the fat. No meat. Even if you take eggs, they are harmful. Oat and butter diet may cause diarrhea. Then, of course, you have to give opium, and that takes care of that. And then in weak or nephritic patients, the well-known oat edema, and it may prove troublesome. And diuretics like thiosin, I looked it up. Thiosin was used in the early part of the 1900s and was given up because it caused a lot of mortality. It is related to theophylline, very close. And we use theophylline today, and it's got a very narrow therapeutic. So you got to give that as well. Coming to the late 1900s, Sir William Osles kind of recognized as the father of modern medicine. He was at Johns, he's a Canadian, but he was at Johns Hopkins. What did he say? He said the usual 65% fat, 32% protein, 3% carbs, and he said, don't take all that fruits and garden stuff, it's not good for you. Then he said, avoid worry, lead an even, quiet life, equitable climate, flannel or silk only near the skin, take a cold bath, a Turkish bath, occasionally get, if you don't want the exercise, go get a massage. And he noted, again, no one drug has directly curative influence. Opium alone stands the test of experience as a remedy capable of limiting the progress. This is Sir William Osler. And then we come, of course, to Elliot Jocelyn, who is considered the father of diabetes in the United States, and the Jocelyn Clinic is there. This is 1916. And this is what he wrote. It was reproduced in the Canadian Medical Journal. He said, when I'm asked to see a new case of diabetes, I beg the physician, don't change the diet or omit the fat till the consultation is there. When the patient comes in, the fat is gone. After 2 days, the protein is gone. Then the carbohydrate is down, and then 10 grams of carbohydrate. That is all. I think this would cure anybody of diabetes if you could stick to it. But he kept very meticulous records. You can look at it. They used to check that. People remember the Benedict solution. You have to take it. I've done that. 10 drops of urine, and you put it on a burner. You get an orange. There were no keto sticks in the 70s when I started medicine. Anyway, this was a keto diet. And just 6 years later, insulin was discovered. And this is one of the original vials from 1923. And guess who made it? The University of Toronto made it in their laboratories. And as Dr. Dr. Thomas pointed out, they sold the patent to Eli Lilly for $1 a piece, because Banting and Best each had $1 invested, because they said this has to be available worldwide. And another interesting fact is the Nobel Prize for it was given in the next year. The fastest Nobel Prize ever given. Why? It was later discovered that one of the members of the Nobel Committee needed insulin. So they gave it and they got the that is good. However, they soon found not all patients respond, because they're type 1s, type 2s, and all that. And they didn't know what is type 1, what is type 2. That was Hemsworth in 1936. He published this in Lancet, and he said there are two kinds of diabetes. One is the insulin sensitive type, appears to be caused by the deficiency of insulin. And then there's the insulin insensitive type. He didn't say. And it's due not to lack of insulin, but there's some unknown factor which sensitizes the body to it, and these people don't have that factor. And guess what? He did the study to prove. You can't read it. He did a glucose clamp to do it. He gave insulin and glucose. He gave 30 grams of glucose, 5 units of insulin per square meter. And I know Dr. Thomas still does this. I used to do these clamps. So he did some pretty sophisticated studies 90 plus years ago. And now, of course, we know there's so much in the pathophysiology of diabetes. I mean, we know the pancreas, the beta cell defect, the alpha cell defect. That's the secretory, the insulin resistance, liver, muscle, adipose tissue, the brain, there's altered signaling, intestine, the gut, the kidney, and then, of course, Dr. DeFronzo made the ominous octet into the noxious 9 last year, because cortisol, a very small minority of people have it. All these cause hyperglycemia. That's the bad news. The good news is, pharma, you get a target, we can fix it. We have all these drugs. For want of time, I won't go. You all know about sulfonylureas, glinides, DPP4s, metformin, TZDs. Bromocriptine is available if you want it. And so it's very expensive. All these drugs are there. And they lower blood glucose levels. And in the years since, we still use these drugs, sulfonylureas, metformin, the DPP4 inhibitors, TZDs. And sulfonylureas and DPP4s really have not been shown to have any significant cardiorenal benefits. And I'll tell you why it is important. They do lower albuminuria, but that's because glucose control improves. Metformin, some, but not conclusive. Actually, I think we're doing the ultimate study with metformin. The VA is doing it to prove once and for all, does metformin have cardiovascular benefits or not? Never been proven. TZDs are potent insulin sensitizers. Pioglitazone has got effects on stroke, but a lot of side effects, and I don't think any of the fellows even use it now, but we used to use it a lot. And the first studies were done right here in San Diego in the 1990s of the TZDs. But only the SGLT2 inhibitors and the GLP-1, I think you'll agree with me, consistent, significant cardiorenal benefits. And this was the best. Now, nobody does head-to-head for all these studies. So I looked at this, it's a lot of stuff, 22 studies, 150,000 patients, and they say a low risk of bias for all of it. And you can see GLP-1s are green, SGLT2 in the purple color, hazard ratio. And this is the 5-year absolute risk reduction. CV mortality, about 1% and a third. And hazard ratio you can see is about 0.88. Major adverse cardiovascular events, which is non-fatal MI stroke or CV death, about 2% absolute risk reduction. And I have to point out that the SGLT2 effect is driven only by CV death, particularly heart failure death and sudden cardiac death. Sometimes very difficult to say, but that's where this is. It doesn't really have any effect on MI or stroke. Heart failure, here's where the divergence. GLP-1 is about 0.8 absolute risk reduction. SGLT2 is about, this is pretty robust over here, 4.25% absolute risk reduction. This is narrowing now. This is because semaglutide and all have got some, and it's slowly coming. The studies are coming. A composite renal outcome, again, a difference over here. Robust effects for SGLT2, 2.75, absolute 0.98, slowly going to narrow over there. Which begs the question, why is it that these diabetes drugs have got such a profound cardio, and nobody knew it? It was very serendipitous. Nobody knew it because the FDA said, you got to do the study and we won't approve the drug. And they found it. Many mechanisms, AGEs, advanced glycation, end products, and, all body mass that you lose. I found out that the skin contains a significant amount of sodium, and there's a way to find out. There's a radioisotope by which, and the SGLT2s reduce skin sodium, which is a big store apparently. Anyway, other things, whole bunch of them, plasma volume, glycemic control, kidney effects. But this one, I think we were the first to propose from here in San Diego in 2016 that ketone bodies may play a partial role for the heart and the kidneys. If we were not believed, when we wrote our paper, within 1 week in Cell, 2 people refuted it. And they said, these guys don't know what they're talking about. But over the years it has. And the person who wrote it finally came and said, I'm convinced of your hypothesis. That was a little bit. But what about GLP-1s? They act everywhere. This is only partial, this is only GLP-1. I mean, I'll talk about this more. It acts on the beta cell, alpha cell, everything, fat and other tissues, body weights, signaling in the brain. I'll come to this a little later. Blood pressure, kidney effects, cardioprotective effects, effects on platelets, effects on postprandial lipids, and all of this causes. Now let's come to the ADA standards of care for the use of diabetes medication 2025. Of course, they say healthy lifestyle, diet, exercise, everything. And then this is glucose-lowering medication diabetes. First, they say cardiovascular and renal risk reduction. If you have atherosclerotic cardiovascular disease or high risk, use a GLP-1 or use an SGLT2. If you have heart failure, SGLT2. As of now, there's no drug. Semaglutide has effects on HFpEF. HFrEF, we don't have data. But SGLT2s across the board, HFpEF, HFrEF, whatever your ejection fraction they were. CKD, and they defined as eGFR less than 60, or you got albumin. First, they said make sure the patient is on a maximally tolerated ACE or ARBs, and then it is first SGLT2, which you should be giving, and then this is something that follows. You can continue it until the initiation of dialysis or transplantation over there. And the studies are going on even in dialysis to see if it does it. Or a GLP-1, which have got benefit. All right, we're finished with the cardiovascular risk. Now we come to weight and glycemic. But no, first go for the weight. That's what they said. If you go left to right, as we read. And which is the semaglutide, tirzepatide, dulaglutide, everything. And then last but not the least, hey, we're going to do something about the glycemic control. These are patients with diabetes. And what do they say? Metformin or anything which can lower it. Where's insulin? Insulin's 100 years old. Well, if you can read that small print, it's over there. Insulin is there after dula, the tirzepatide and all that. And so 100 and few years after that, diabetes is now cardiovascular, renal risk reduction, weight, and then, okay, you can use all these drugs over here. It's really, I feel it's a paradigm shift. We've completely moved away. So where do we go from here? Well, I think SGLT2 inhibitors, in my opinion, we have maxed out. We've got all this EMPA, DAPA, CANA, approved for diabetes treatment and cardiorenal protection. We have one dual SGLT1/2 inhibitor, so Gliflozin, which is there. It's only approved to reduce CV, death, and heart failure hospitalization in people. And it will increase the risk far more than the SGLT2s for DKA and euglycemic ketosis. It's not recommended to be used. Maybe we can get new indications. It's got some effects on atrial fibrillation, renal transplant, muscle, type 1 diabetes. When we get the continuous ketone monitors, which will be available next year, maybe we could go there. What about GLP-1? So just to reiterate, GLP-1 stands for glucagon-like peptide. So the main gene is the pre-pro-glucagon gene. And GIP is glucose-dependent insulinotropic polypeptide. It was initially called the gastric inhibitory peptide, and now we call it this. They're the classic incretins you all know. After a meal, they stimulate insulin secretion in a glucose-dependent manner, so you very low risk for hypoglycemia. Very quickly to go over it, this is GLP-1, and we see effects: increase satiety, decrease food intake, increase nausea, reduce body weight. And the red is, they've got receptors there in the brain. Of course, acts on the pancreas to increase insulin, decrease glucagon. Slows gastric empty. There are human studies for all of it. And all these three lead to lowering. Purple is systemic effects, secondary effects. The liver, it improves insulin sensitivity, shuts down, restrains hepatic glucose production, and ectopic lipid is also there. But this data is changing. This is from 2020. Probably they're finding, as of now, most people think there are no GLP-1 receptors in the liver, the muscle, and in white adipose tissue. They're in the vasculature or the immune cells or something there. They're not really there as of now, definitely. GIP is a little bit of a, what do you call it, pinch hitter. It helps GLP, and then guess what? It reduces nausea, it doesn't increase it. So you get better tolerability when you combine the two. And of course, it's got its punch for the body weight and food. Here, it increases glucagon. But that effect, I think, is dampened out by the powerful GLP. And I'm not going to go into how much. It's a partial, it's a little effect there, little effect there. It's got quite robust effects in white adipose tissue, improves their sensitivity, storage capacity. And actually, initial gene studies showed that it's an obesogenic gene. And then they found, no, that was not true. Of course, lowers hyperglycemia, triglycerides, skeletal muscle, and this also might apply to this over here. GIP is got in human studies effects on bone in the prandial state, not in the fasting state. GLP-1 also has some effect. Of course, there's cardioprotection. And one thing you have to remember, GLP-1s, all of them increase heart rate, about 6 to 8 beats per minute. It's there, it's a complicated. And this is direct and indirect effects, and also the renal effects are there. So let's look at it. What has the FDA approved for all these medications? Type 2 diabetes, it reduces A1C depending on the agent, 0.8 to about 2%. These are all the drugs. The brand names, Dira, Beulah, Sema, Oral semaglutide is called Ribelsis, tirzepatide is Monjaro. These are all the diabetes lowering drugs. Then you got obesity. Now 1.8 to 8.5 in diabetes. These are the original studies with liraglutide at the diabetes dosage in patients. They don't lose much weight. But in people without diabetes, and we all know that people with diabetes don't lose as much weight, no matter what. It's far more difficult for them to lose weight. And you have these same drugs, but at a different dosage, Saxenda, Wegovy, Ribelsis, tirzepatide, and they cause quite robust weight loss. Cardiorenal, I think we all know about Lira, Semaglutide. Dula is not really for DKD, but has benefits. In non-diabetes, Wegovy has got the FDA indication. My personal opinion, they're all the same. The more potent they do it, depends on tolerability, depends of course on insurance. Then DKD, semaglutide, got approval earlier this day for CKD on the flow study. Tirzepatide study is still going on. SEMA, the study is positive, but the FDA hasn't given approval. And here's our San Diego connection again. Not the summit trial. Sleep apnea. I think we'd all discussed it. Dr. Malhotra was the lead author. Approved by the FDA for sleep apnea. Is it the weight loss effect? Is it something else? Somewhere else? I don't think anybody knows. And of course, for MASL, Dr. Rohit Loba was the lead author on it. It is FDA approved as of August. Investigational, there are still some studies going on with tirzepatide and Parkinson's. There are studies going on. Alzheimer's, it's fascinating. There are studies going on. Evoke 1, Evoke 2, over 4-5 year studies over there. The VA is doing a study in alcohol and substance use disorder. Peripheral arterial disease, 2 studies have been published. Liraglutide, Stardust, semaglutide, they improve the parameters, but FDA will not give you for very soft outcomes like this. They won't give you. Now, these have profound effects on type 2 diabetes obesity. What if you add glucagon? The other guy sitting there in the pancreas. Now, the question is glucagon a friend or a foe? It's approved to treat low blood sugar. The fellows all know we have to write the prescription because it raises blood sugar. So people said, oh, let's go and block the glucagon receptor antagonist. It's pretty good. It lowers blood glucose in type 1, type 2, but there's a major problem. And Dr. Powers can speak more to it. It fills the liver with fat. Blood pressure goes up, transaminases, cholesterol goes up. To my knowledge, I don't think anybody's going forward unless they tweak it. What about an agonist over there? And the other thing which you have to watch for the glucagon receptor antagonist, there are human mutations of the glucagon receptor. They don't get diabetes, but guess what they were found? They had huge abdominal masses of glucagon hyperplasia because the receptor is blocked. Nature is trying to compensate over that, and you got to be careful. So if you can't beat them, join them. Okay, add it on. GLP, glucagon, triple, use all of them and see what is it. And the mechanism, I told you about GLP-1, what all it does over there, and you know that. What does glucagon add? Glucagon is catabolic, increase energy expenditure, there's thermogenesis, it reduces liver fat, FGF21, bile acid secretion, and also decreases de novo pathogenesis. Now, it does increase the glucose a bit, but that is overpowered by GLP-1. And when they're given together, and many peptides all over the world, survodutide, efinopegdutide, mazdutide, I won't go there. Just one, it reduces A1C by 1.7, and in the same study compared to 1.5 with semaglutide, which is a pretty potent drug. Body weight, almost double that of semaglutide. This is in patients with diabetes. There are more side effects, mostly GI, but about 10-12% of people did drop off. The studies are going on. And MASH resolution in 62% versus 14%. Relative risk reduction. Now let's add the other guy. Why should we leave GIP out? Right? GLP, GIP, glucagon. And I picked this up. I don't know, we've all read Alice in Wonderland by Lewis Carroll. But Allison, I mean, he's written many stupid novels. So this is The Hunting of the Snob. And there's one quote that said, when I tell you 3 times, it is true. But that was, look at the colorful language from the New England Journal of Medicine. Triple G agonist, a home run for obesity. Luckily, they put a question mark at that. And that refers to retatrutide. What did it do? These people are around 110 kilos, BMI of 37, and they're pre-diabetes. They don't have diabetes. Look at it. Almost 25% relative risk reduction. That is bariatric surgery thing. And this is over 48 weeks. Of course, you stop it, it comes back. Side effects, very briefly, what the side effects were. Not that thing. It's there. I'll just point out there's one death here, few serious errors. Yes, vomiting, diarrhea is there up to about 16%. It is there. We have to take cognizance and they have to learn how to titrate the drugs. But what about effects on MASH? So this was studied in MASH and it found Rita 8 and 12 reduced steatosis in 85% of patients. Liver fat was achieved. Once you get to 20% reduction body weight, your liver fat almost vanishes. And it is related, of course, to, you improve insulin sensitivity. And guess what? This was a senior of the Arun Sanyal. I know he's a good friend of Dr. Ruba. I also know him. Virginia Commonwealth University said it. Retatrutide wiped out fat in the liver of obese patients. I think it's a little bit too much of hype. But I think GLP, glucagon agonists are indeed very robust in reducing body weight, glycemia, and muscle. But we're not done yet. The gut peptide jungle is getting thicker. Amylin. Now this is the mystery nobody has been able to solve. Amylin is made in the beta cell. It makes insulin, it makes amylin. And we have no idea why. And guess what? This same amylin in patients with type 2 diabetes, what causes their reduction? This is for the NO2 fellows. Type 1, it's autoimmune mediated. Type 2, it's the islet amyloid peptide, amyloid. It destroys the beta cell. The same amyloid localizes in the brain and causes Alzheimer's, which incidentally, for people who didn't know, Alzheimer's is called type 3 diabetes by some people. There's insulin resistance in the brain. Leptin secreted from adipose tissue. Why did we forget these people? And interestingly, the jungle is so complex. Amylin actually belongs to the calcitonin family of peptides. Calcitonin is approved for bone metabolism. We know that over there. Amylin, energy and glucose, and the calcitonin gene-related peptide, and adrenomelanin deals with blood flow and all that. And the first amylin analog has been approved, but we rarely use it. CGRP is approved for treatment of migraine. This is not used. And amylin peptide is there for want of time and space. It's called cagrilintide. And guess what? It is called a DACRA. And what's a DACRA? Dual amylin calcitonin receptor. And that receptor complex is so fascinating. There's a RAMP1, RAMP2 receptor modifying proteins. These things are all, and I told you, amylin goes to the brain and causes Alzheimer's over there. But amylin also restores sensitivity to leptin. So they both are kind of co-partners in this. Amylin, if you do it, less nausea and vomiting, although it can go. And this is the big one, less muscle loss and potentially longer lasting weight loss. You stop your GLP-1 within 4 weeks, it all comes back. But with amylin, there's something of a resetting. I don't know, I'm speculating too much. So we saw the GLP-1 monoagonist, we saw the GLP-1 GLP, we saw the triple. Are you ready for the quadruple? I'm sure you are. So let's look at it. Now the power of 4. This is very intriguing. So Biomed is a compound in California. It's got a compound called bioglutamine. And guess what? It's the first quadruple agonist of GLP, GIP, glucagon. And I bet you will never guess the fourth thing. IGF-1. Well, I don't know if you know, the fellows know this is
Bad idea.
well, I've used IGF-1. We did the study to see if it can treat type 1 diabetes because IGF-1 at high doses signals through the insulin receptor. But it causes more mitogenic effects than the MAP. We did the study and it was abandoned because people got joint pains, acromegaly, but it improved the blood glucose. Anyway. And in phase 2B clinical trial, I don't know how to believe this, 13 weeks, the one with 50 milligram dose orally reduced body weight by 50, about 14% of people. It presented this at EASD and ADA. No published publications. It's like people find it difficult to believe you can take 4 peptides, make it a normal molecule. I don't know how it is that. And this is even more. No differences in GI related adverse events. And I know this morning at Journal Club Endocrine, we were talking about adverse events. That's what he says. No muscle loss. So it's almost like a miracle pill. I don't know. We'll find out. And this is the big thing that we have. We all overlook it. I don't know about you guys. I have patients, 5%, they come back and say, stop the Gliflozins, stop the GI, I can't take it. The wife says, I don't recognize this person. He's all skin and bones. Sarcopenia, can't get up from the chair. I'm like, what the heck? The BMI was 32 and now it's 23. No, you lose muscle mass also with it. So it can. So the general recommendation now, so just a quick, it's very difficult to get this data, but I got this from, Chris Montzoros came and gave medicine granule a few months ago. So let's look at weight loss with incretins. How much fat, how much lean body mass? So this is the body composition post-treatment. Green is good, you lose body weight. Red, brown is not good, you're losing mass. So semaglutide, 2.4 milligrams, 68 weeks, you lose about 15% body weight, but you lose 39% of that is lean body mass. Now, a portion of people got DEXA, that's how you can calculate it. So if you take a 200-pound person, they lose about 30 pounds of total body weight, but 12 of it is muscle. Treated through diet at 36 weeks. A 200-pound person will lose about 34 pounds and only 11 pounds. Now, there's something with the glucagon is actually catabolic. I don't know how it does it or doesn't do it. I don't know. Tirzepatide, and this is at 72 weeks. You're losing 20%, about 200-pound person, 42 pounds, and only 10 pounds is there. So it seems as of now, all these things are how they measured it and all that. Bariatric surgery, this is the 10-year data from the Swedish, all these studies over there. And you lose 25%. So 200-pound person average weight loss will be about 50, which is about 25% of your body weight. And you lose about 12 pounds. But this doesn't take into account sustainability of weight loss, effects of weight gains, or changes in lean mass. We really don't know. This is at the beginning, at the end, you do it, and we don't know. Then there's quality versus quantity of muscle. You have the muscle, but it is like a flabby muscle. So that's why we, at least I tell our patients and follow them, increase protein consumption. You can argue about how much, depending on the kidney function, and they have to do strengthening exercises over there. But guess what? Pharma has a solution. We've got drugs to fix it. All right. What are they? Anti-activin. So there's a drug called Bimagrumab, but it was stopped and no explanations given why. And for those of you interested, in Indian mythology, you might remember in the Maha, there is Bhima, who and they named it after Bhima. He's a giant and he something like Goliath. He was a giant. So for some reason they called it Bimagrumab, but unfortunately it's not. Anti-myostatin agents, Apitegromab, I don't know, I can't even pronounce it. Promyostatin latent. All this is coming from the spinal muscular atrophy. They said, hey, why don't we use it over here? And it is there. And I don't know if you know, there are human mutations of myostatin. There's a famous New England Journal paper picture of a 3-year-old German kid, and you can Google it, it is there. A 2-year-old boy looks like Arnold Schwarzenegger. I don't know what happened to him after that. Nobody's published that. Anyway, then you combine the two. If one is good, two is even better. And this is Trivogruel. It's all going, I don't know. With or without carotisoma, I don't know. And then, hey, let's modify the androgen receptor. It's an oval selective androgen and enobosmom. And the studies are going on to see if you can get only fat loss. So, why are we preventing obesity in the first place? And I took this from the Caribbean thing on World Obesity Day. I think it's March 4th. This is causes of obesity beyond diet and exercise. Genetics is about 40 to 70. We know that over there. Lifestyle factors, I think we had the physician burnout lecture with the lack of sleep, high levels of stress, everything over there. You guys are all physicians, burn out and you will gain weight. Not you, Dr. Ghosh. Sorry. Anyway, physical environment is there. We all know about it. Unhealthy food. Like your patient says, you eat healthy. Where's the money to buy? You can get a burger on Tuesdays at McDonald's for $1. You can't get any fruit or vegetable for $1. Lack of access. Life events, of course, early prenatal. Now we have all the data for that. But you can't do anything about your genes. I think so. Lifestyle, you can try. Life events, some of them have to occur, and for all of them have to occur. Can we change this? This is what industry gets off it. You thought of pharmaceuticals. I mean, industry is very far. They will give you what you want. You want taste, you want salt, you get it. But we have the brain, which is supposed to put. Now, this is a little complex, and I'm coming towards the end. So bear with me. How does the brain regulate it? How does it know what you're going to eat tomorrow, what you're going to have for dinner? Suddenly, you get an invitation to a French restaurant, wine and all. The brain has to decide, right? So we all know about the hypothalamus sitting right up there over there. It's the central integrator of homeostasis, whether it's your blood pressure, your temperature, your body weight. That's the hypothalamus. And there's the lateral, the ventral, the dorsal, and all of it. Then sitting close to it is the dorsal vagus complex. And I never knew about it. This regulates gut motility. Vagus is the secretor motor for the gut. In the old days, before we had H2 receptor, in the 70s, guess what we used for people with peptic ulcer disease? Atropine, block it. They got all this thing. You didn't have any treatment. Digestion, energy, heart, lung. Anybody know why it's called the vagus? Fellows. I tell it to the fellows. It's a vagabond. It starts over there and it goes all over the body. That's why the Greeks called it the vagus. Anyway. All right. So then, the hypothalamic nucleus, AGRP is agouti-related protein, NPY is neuropeptide. It's one of the most potent appetites. You give it to mice and all that, and you will know they will eat up anything over there in the environment around them. And they too are the gas pedal because you stimulate them, you increase your energy intake, and you decrease your energy expenditure. It's two sides of the coin. But look at these guys there. This over there, that arcuate nucleus, POMC actually stands for pro-opium melanocortin. And we know the MC4 mutations and all that. But this is very surprising. COT stands for, it's very difficult to find out what, cocaine and amphetamine related transcript. So this is the one which is signaling in the brain. What does it do? It's the brake. It reduces the energy intake and increases energy. But these two guys cannot work with the dorsal vagal. And this is the practice of the nucleus solitarius. We all know the way it goes and comes up with the fifth curve, it's going there, the dorsal market, and then the area postrema, which is the vomiting center, whatever it is over there. They all, and they respond to these signals, leptin and insulin. These are the two well-known regulators of long-term body weight. And one of my mentors, Dan Ford, reinforced that to me. He said, insulin is a regulator and it regulates body weight negatively in the central nervous system. If you give nasal insulin, I'm not talking about inhaled insulin, you give it straight here. In humans, you give enough, body weight goes down, no hypoglycemia. But peripherally, insulin increases your body weight, it's an anabolic. So these are all these discordant peripheral versus central effect. So this is all central. These are the peripheral guys going over there. And they act on the POMC cart, they are the brake. Then the pancreas, you have GLP-1, GIP. What do? They are also the brake. They don't let you eat too much. Then you have the other cells, protein YY and oxyntomodulin, and they also apply the brakes. Then the pancreas makes a pancreatic polypeptide and amylin. Remember, these guys come from the gut. This comes from the pancreas. And what do? They signal to the dorsal vagal nucleus. They don't signal over here, and they're ready. And a few words more on the vagal afferents. They're all over the body, as I said. Nutrient receptors in the stomach, stretch receptors, chemosensors. Cholecystokinin, actually, my mentor told me, is a very important short-term meal-to-meal regulator of body weight. And of course, they all act at the dorsal vagal. Great. What does ghrelin do? We all talk about ghrelin. It's the gas burn. So there's this one single guy trying to oppose all of these other guys and trying to keep your weight up. But the default in human metabolism is you should not lose weight. The body will defend and keep going in there. So it's fighting a losing battle. All this will determine your meal timing, meal size, energy expenditure, and reproductive competence. But something overrides it all, and that's the hedonic thing. That's dopamine sitting in the mesolimbic system, the brain. And none other than, you should read this book if you haven't. David Kessler was a former FDA commissioner, and he was the COVID czar in the previous administration. He gained 40 pounds during COVID, and he went on this drug. And he wrote a beautiful book saying, diet, drugs, and dopamine. And look at that. There's an injection going through a chocolate cake. All right. I think the need of our time is diabetes prevention, remission, cure. And as Dr. Mudaliar said, we are still running the diabetes prevention program right here in San Diego, 30 years and counting. What about technology? I didn't even talk about it. Insulin pump, CTM, artificial pancreas, immunotherapy for type 1, islet transplantation, gene therapy. Work is going on. I mean, I don't know, it will come in 1 year, 5 years. And Dr. Ghosh gave an excellent talk on this, precision medicine, the gut microbiome. In fact, somebody said, you are what you eat, but actually now they say you are what you feel. Because that's going to determine everything. I think we've come a long way in 5,000 years. From Hesira with his treatment, and then we use herbs, chemicals, diets, meat, oat, osra, whatever you want. Then the keto diet, and then we got insulin. And I do another point about insulin I'd like to mention, because you forget this history. The two guys who got the Nobel Prize was Banting and MacLeod. And MacLeod didn't like it. He didn't want to go. But the Canadian government said, you got to go and get the prize. So MacLeod gave his prize to James Collett, who was a biochemist, and Banting gave it to Best. And Banting and Best suppressed all the literature, and only recently, when both the spouses were dead, the papers are coming out. And you can read it. Banting and Collins, they came to blows in the lab, physically. And that's the story of the Nobel Prize. Unfortunately, Banting died during World War II he was a pilot and he died. Anyway, you've got all these drugs, sulfonylurea, metformin. Sorry? Don't get a Nobel Prize.
Don't fly the plane.
He was actually an orthopedic surgeon who went to MacLeod and said, give me your lab, I want to do these studies. Metformin, TCD. Metformin's got a fascinating history. Sulfonylurea have a fascinating history. They were used as, I don't know if you remember, from the 70s. We had sulfanilamide. We didn't have. We just got tetracycline came later. Penicillin was not available in India. We used sulfonamide for it. And therefore, people were getting hypoglycemic. Anyway, Eugene Braunwald calls SGLT2 inhibitors this. Anybody here know who Eugene Braunwald is? He's still living. The first founding chairman of medicine, preceding many people, 1968. His daughter's an endocrinologist, and he still gets talk. He's 95, like 6 years.
Just got an email from 2 weeks ago.
I've spoken to Alice, and she says, I don't know how to stop this man. Anyway, and then another San Diego connection. 2005 was excellent time, and this is from NBC News. It was called Lizard Spit right here in San Diego, a few blocks down. It was made by a company called Amylin, which doesn't exist anymore. It's got another story behind it. And the patent for it was held by a VA person. And he went to the VA and said, I've discovered this. I don't know what it is. They said, can you do anything for veterans? They said, we're not interested. So he sold the patent to Amylin. And then only the VA has now cracked down on it. Anyway, this is from The Economist. They said they're among the most important breakthroughs, and they gave a Swiss Army knife, diabetes, weight loss. These all approved. I forgot to put liver disease there. And this is all over there. But we have lots of issues with cost, access, all of that, and many more coming down the pipe. And millions of Americans will it bankrupt our healthcare system. So I'm ready for questions, but I want to remind you of what Voltaire's real name was François-Marie Arouet. And he said, judge a person by his questions, not by
That was terrific. Just I was surprised to see POMC causes decrease in body mass. I would think it would release adrenal, corticosteroid levels and go up.
But it's the pro of your melanocortin, so that thing has got, it's divided. Now, I hesitate to venture into it, it is kind of spliced in different ways, some other people can tell it. It is the corticotropic, but that ACTH part is separate from the other part. Correct me if I'm wrong, but MSH, melanocortin.
MSC.
What's that?
ACTH, MSC.
Yeah, they are all,
But wouldn't the ACTH component of it?
but it's clean, it's simple. But it's a good question, I will go back and I will email you.
I have first part was a historic part of the question, which is, I was curious why opioid was hammered repeatedly, because shouldn't it cause hyperglycemia? So that was just a curious question, why over history, book after book, go for it, narcotics, okay. So that was just a curious question. My second part is, we thought we cured or we would cure obesity and diabetes when leptin it was like, oh, it's a done deal, it'll cross the blood-brain barrier, has its receptor get done. Then we recognized that obese people downregulate the receptor. And so would you almost say that some of these newer peptides we're hitting, we got somewhat lucky in one big part, which is the crossing of the blood-brain barrier. The reason being, we were just out of luck that leptin needed a saturating concentration of a specific receptor that had no other way to cross the blood-brain. But these newer ones, they have 4 or 5 ways of crossing the blood-brain, one being just diffusion. So all you needed to do is you could, and the others being carrier transport, the transporters help, and then the third being, yes, receptor mediated, but receptor mediated transcytosis right through the endothelial barrier. So the question is like, should we be looking into some of these other ones which we're thinking of, but making sure we don't have a decade of failure with leptin that we went through? Because leptin was one of those investments that just kept us for a decade thinking, oh, there's hope, except we missed the biology of how it should get into the brain.
Maybe your precision, the talk you gave last week, so go talk to pharma and tell them how to do.
But some of this is almost like it's engineered driving. Let's add 4th drug, let's add 5th drug, let's add 6th drug. Sometimes not
Much
much
far
fruit.
smarter now than they were 10, 20. We did the studies with that in the late 90s. Its effects on A1C were like 0.3. Of course, people have leptin resistance. It's a complex molecule, which is there. And I think the first part, I think you know the answer to why opioids.
Why? Yeah, I don't know what. So we just don't know about the reality by staying stoned. Yeah. Okay, we heard our care of medicine, the treatment to all of the woes in life is staying stoned. No, thank you. That's a misquote, but
But to your point about when one of my mentors died poor. Now, that's in I think it was 1995, the famous Jeff Flyer paper. It went wide cell and everywhere. Leptin is a big molecule.
Yeah.
My mentor, Dan Ford, in the 60s, he said insulin acts on the brain. He couldn't get his paper published for 10 years because I said insulin, I think I believe it's 60 kilodaltons or something leptin. He said when leptin came, everybody accepted it. And now we know there are gaps in the blood-brain barrier. And there's some evidence in humans also that the brain makes insulin. Now, so it's there. You can look at it, and it's there. Okay. And you give it through the crippling strong side of the endpoint, you get effects. So nature never ceases to puzzle us.
Thank you.
But thank you for the question.
There's a question from online from Sunder Mudaliar. What are the concerns about IGF increasing cancer?
Oh, yeah.
I mean, she brought it up right up front. I told you this is a mystery molecule. The guy, with Dr. Tran, if you ask questions, it's like he's sitting in the White House or the press room, But sometimes you just ignore the question and move on. It's not been published. It's been presented as abstract. So I don't know. I guess, and I told you the study which we did, everybody was dropping out. They got swelling, they got joint pain.
I mean, if there's anything that came out of the Rancho Bernardo study that did show that that a metabolic syndrome cancer risk is squarely implicated to IGF. And IGF binding protein being high protects, IGF being high causes the more risk. So I mean, this is.
There's something mysterious about it. I put it out there just for what is there, because it was presented as the American Diabetes meeting and the European EASD meeting in September. He's getting, I think,
I'll ask my own question. You started with diabetes was one thing, then it became type 1 and type 2. Now there are different definitions. There could be like 8 types.
Five.
Franzo has like the omnicide.
no, that is the pathophysiology,
Yeah.
but the official, it has to be agreed to by the across the world, mainly AD starts it, the Europeans, the IDF. Now they've already proposed a type 5 and all, it's controversial. What you're talking about, yeah, that's question.
So to what extent do you think that is going to be really important to select how to treat people, or should it really be a sort of a one size fits all, give everyone SGLT2s and GLP-1s?
No, it has to be individualized, that's why they said look for this. If in addition to the diabetes, they have cardiac, they've had an MI, they've had a stroke of this thing, then use an SGLT2 inhibitor. If they've had that, use the GLP-1. Now, we have to presume this is based. Now, if there's a guy like yesterday in our conference, we were talking about somebody 30 years old, BMI of 20, diabetes, and it was one of these mitochondrial diabetes. And really a GLP-1 would not be. So it's a good question you're asking. And people need, maybe I'm going to put another blurb saying individualize it. That's the fair question.
We've got another one from online. What do you think the teleology is behind the extraordinary complexity of gut neuropeptide signals? Is there to help animals seek out foods they need in a refined?
Is there a what?
Is the gut neuropeptides, are they there to help animals seek out foods in the refined fashion?
Somebody who's asking me clearly, I don't do animal studies, I'm sure it is there. We have evolved over millions of years. Actually, insulin is about 600 million years. It is present in the teleost fish, which is the tilapia. It's got an insulin like a pancreas-like organ. You take it out, the fish gets diabetes. You care for it, but it gets diabetes. And GLP-1 is also found in that, the incretins. So these systems are very ancient. But you should do the GWAS. You have an extraordinary, mechanism to try and tease out all this.
All right, well, thank you for a fantastic talk.
Oh, I forgot to put that.
Yeah, it's like that.